Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Today, a discussion about the nature of evidence between Johns Hopkins faculty Dr. Arturo Casadevall and Dr. Josh Sharfstein. Their starting point is a recent article by Dr. Casadevall published in the Annals of Internal Medicine, in which he criticizes how medicine, the quote, youngest science, decides what data matter the most. Let's listen.
Dr. Arturo Casadevall, thank you for joining me in Public Health on Call to talk about a challenging topic, which is why everyone seemed to disagree so much about data during the pandemic. And let me just set the stage here. Even today, people disagree on what works and what doesn't work for treating COVID-19. Some people disagree on what works for preventing COVID-19, such as to what extent do masks work. There is a lot of argument back and forth. And it seems like every time a study comes out, everybody runs to one particular conclusion, and then maybe they run to another conclusion. I know you've thought a lot about evidence and COVID-19. So where should we start?
Well, we can start, as you know, Josh, I'm primarily a science-based physician scientist. I run a lab, I run a basic science department, but the pandemic threw me back into clinical medicine. As you know, I was very involved with the convalescent plasma efforts in this country. And seeing how the clinical decision played out in the use of plasma alerted me that I think that we have a lot of work to do.
You know, in medicine, there is what some people would call a hierarchy of data. That if you just take care of one patient and you see a response, well, that might have been a fluke, you don't know. If you look at a whole bunch of patients, that's better than looking at just one patient. And what people call the gold standard is a randomized controlled double-blind trial where people who are conducting the study don't know the treatment that people are getting. And therefore, it is the strongest design to assess whether something actually works. How has that made it easier to figure out what works or made it harder in the pandemic?
So what I would say is that we have to be very proud of the enormous progress that medicine has made. In a blink of an eye in human history, medicine went from testimonial superstition to really beginning to incorporate science. And a lot of the great successes that we've seen in the late 20th century has been the result of incorporated science and taking a more rigorous approach to what we know. Medicine, as Lewis Thomas called, was the youngest science. It is still trying to deal with the difficulty of how do you evaluate evidence in making treatment decisions. But what I would say to you is that coming from the world of science, we are taught that data is data and you cannot throw it out unless there is something wrong with it. What I'm struck with is that in medicine, as you very well just pointed out, medicine has already achieved a hierarchy and is willing to throw out data without necessarily showing that there is something wrong with it on the basis of assumed rigor.
So there are a couple consequences to this hierarchy of data. One of them you just mentioned that, well, if we've got a better study, then maybe the other ones get tossed out. Another is sometimes there is no better study to be done, better in quotation marks, because you just can't do a randomized study for something. And then people sometimes act like there's no data, basically, or that the data that there is can't be trusted. And then I guess a third question that I will have, maybe we can save it for later, is what's the role of logic and theory in assessing data? How does that work? Is it purely an empirical question, or do you bring some understanding of the underlying phenomenon to the interpretation of data, which also I think is one of the things that can be confusing as people sort through the pandemic data. So I'm just trying to throw a few issues out there. But why don't we start with the one that you mentioned first, which is, why wouldn't you just say, well, we've now got a gold standard study, let's just move on, this question has been answered? What's wrong with that?
I would say, how do you know if that's the gold standard? Has it been validated? How have you validated? To me, a randomized controlled trial is an instrument. Instruments need to be calibrated. And instruments need to be validated with other measurements. Medicine has rapidly assumed that this is the best instrument. And there are reasons for that. We know that controls are critical. We know that bias can come in. We know that that there could be placebo effects. So it has a lot of inherent strengths in the way that it is designed. But just because of that, it needs to justify its place as the gold standard. And certainly, when you design a clinical trial, as was done with convalescent plasma, without considering biological plausibility, the instrument cannot give you the right result.
So what you're talking about, I think, from a recent article that you wrote, is that the idea behind convalescent plasma, which is using the antibodies of people who've recovered from COVID as a treatment for others, is that it would work earlier rather than later in the disease. And because later in the disease, the problem isn't so much the virus, it's the body's response to the virus.
Correct.
And randomized controlled studies that were done later in the disease, therefore, wouldn't necessarily answer the question of whether it worked. Do I have that right?
You're absolutely right. I mean, if you look at the most influential trial, Recovery, the largest, people want large trials. The median of randomization was made 2 days of hospitalization. Think about it. You randomize, then you order the plasma. You're talking about a time-sensitive therapy. It's an antiviral therapy. We know that Paxlovid works in the first 5 days. Antibody is not going to reverse inflammation. So then you can put in a methodologically rigorous study. But if it doesn't ask the right biological question, the answer is not that useful or useful for how we're going to go use this therapy.
And it wouldn't justify necessarily tossing out data that may not be from that kind of study, but is the data that's available for earlier in the disease.
Exactly. I mean, you're phrasing it better than I could. You have a lot of data. Some of it is dose response from the FDA's registry study. Others are large observational data. You have real world data, all suggesting that this is reducing mortality. And then you have some, because some RCTs did show evidence of efficacy, that don't. And then what physicians did in many cases is they threw out an entire body of data without looking at the actual instrument. How was that instrument designed to do the RCT, and saying, was that biologically plausible?
So underneath some of these debates over whether a particular treatment may work may be these assumptions about what kind of evidence is at the top of the chain. And so that's one reason why people are going back and forth, and it seems very difficult to sort through. I think there's another reason, going to the point that I made, is that sometimes it's very hard to do a randomized controlled study. And the evidence that you have to use comes from multiple different other types of studies. And for me, the mask question kind of falls into that. Now, there was at least one randomized controlled study that was done in a very different environment from the United States that did show some impact of masks, although I noticed a lot of people looked at that number and just assumed that number could carry over into any other environment. Like, the potential efficacy of masks. And they said, well, it's not that big a deal. It's like, well, I mean, it kind of depends on how masks are being used and a whole bunch of other things, which then you can look at other data to understand. And so this maybe was a case of there being a study that was, like your example with plasma, not really well aligned with the right question. But I also think of it as just how little attention was paid to other types of data, multiple studies showing an impact of mask wearing on viral transmission.
I completely agree. That's another excellent example where you could have gone through the physics of droplets, you could have gone through distance, you could have gone through airflow, size, force, and I think that those issues are often not brought into the debate. You look at the outcome of a trial, the outcome of the analysis, without as you pointed out earlier, the logical underpinnings of what one is trying to do.
Now, I've heard people say, like, look, people had logical underpinnings that, like, the sun revolved around the earth, and the logical underpinnings that you might have one day might change the next day, but evidence is forever. And so how is it that we should include logic in thinking about evidence?
The first thing I would say is that guidelines committees and physicians should not throw out data unless it's clear that there's a problem with the data. So if you have conflicting data, the way to resolve it is additional work. But until that time, you cannot throw it out. And when you're dealing in a pandemic, when you have no therapies, and you are basically in an emergency situation, one needs to weigh these situations very carefully. And as we pointed out in the article, the decisions involving convalescent plasma, hydroxychloroquine, and steroids all show a vulnerability on decision making. And what we found is the common denominator is, in each case, there was a violation of biological plausibility.
Talk to me about hydroxychloroquine, because in that case, there really wasn't an underlying logic. There was potentially some lab data that showed some activity. And so how do you think that story went?
So I think, we're dealing with a pandemic, we're dealing with a high mortality. There is information, in vitro information, that hydroxychloroquine can inhibit viral replication. That information, then there is some observational data suggesting that it may be beneficial. But there are big problems, as was pointed out in that clinical data. And there was another issue that should have weighed very early on, and that is the pharmacokinetics. Is the concentrations that you achieve in the plate in vitro comparable to what you're going to achieve in vivo? So you could imagine that I don't have any problem with carrying out studies for testing it. You often get a surprise in medicine. But what I would say is the physicians continue to use it even after the FDA, for example, in other countries and things had pulled the EUA authorization.
So for you, it's not, I just want to be clear, it's not that if there's any evidence, then you just assume that it might work. What you're saying is look at all the evidence.
Exactly.
And apply your critical thinking. In the case of hydroxychloroquine, the evidence was not that strong on balance, particularly because of the issue of the concentrations of the drug.
Correct. And in the case of the steroids provide another fascinating foible. Basically, we know how to use steroids. We've been using steroids since the 1950s. The recovery trial in the spring of 2020 shows that if you treat patients in the ICU with the steroids, they're more likely to survive. That finding is now extrapolated to across it. But you and I know that steroids are immunosuppressive. There are many stories of physicians basically admitting patients and taking them off steroids. Steroids being started too early in the course of the disease. We now have evidence that if you give steroids early, that's associated with increased mortality, which is not surprising. You're giving an immunosuppressive agent to an individual who's mounting a life-saving immune response.
So in a sense, this is the flip side of the challenge with convalescent plasma, where people may have concluded that it didn't work because it was so late in the disease. Here, when steroids did work so late in the disease, because the response really was the inflammatory response, you're worried about the danger was coming from inflammation, people then assumed, well, then it must work earlier. when really that didn't make sense. And so the rigor, that's a word that people use sometimes.
Yes.
The rigor of just looking at clinical data can steer you wrong.
You said it earlier. You have to look at the totality of the data, and you need to think about the science behind it. How are things working? Is this plausible? Can I achieve this concentration in tissue? Does it make sense to give steroids to somebody early on?
It's hard to come up with a simple way of applying evidence to be able to make those judgments. I completely agree with you. You have to. It's hard to be simple about it. It is easier if you just say, we're going to follow this kind of study wherever it leads us. It's harder if you say, let's sit down and bring in all that data from different perspectives. I know that this is not unique to medicine. I think I've read that in intelligence gathering, this comes up.
I'm sure.
Where you have lots of different pieces of data, and how do you get people together? And we actually did a interesting podcast earlier with Professor Gleed, who was talking about the synthesis of data and how to really think about it. And there are models in other fields for really looking at very different kinds of data and trying to figure out what's the story that holds them together or the most compelling story. But I don't feel like a lot of the tools we have in medicine necessarily are consistent with that.
I think you're right. Medicine needs an epistemic reformation. As you know, I came to Hopkins because I was interested in improving graduate education. I thought scientists had problems in the way that they process information. And we launched the R3 program, which tries to put the PH back into PhD, put critical thinking back, teach it to scientists. I think that, if anything, this experience suggests to me that we need to do the same thing in medicine. Physicians are walking around with the knowledge of humanity in their cell phones. What we need is more to give them the capacity to interpret and to synthesize it, rather than the way in which we often teach, which is, to provide a barrage of information.
In other words, doctors need to think about what's going on and look at all the evidence and how it fits together, rather than just flip right to the latest large trial and apply it, even if it isn't exactly the right fit.
That is correct. And one of the trends that is against this is that, as you know, we've been taking basic science out of the medical school curriculum. When you and I trained, there were 2 years of basic science. Well, that has been changed quite a bit. I'm not suggesting going back to the way you and I trained, but I am suggesting developing a new way to teach physicians how to integrate very different types of data, often in an emergency.
I'll tell you what I remember from my medical training, because I was in an experimental curriculum at the time where we just had like one lecture a day, and then we had like 2 to 3 hours of discussion of cases. And the discussion was really what's going on here. And it was almost like a mystery, and we had to piece together all the data that we could find about a patient. I feel like I did understand the importance of different kinds of data and how to put it together, primarily from that kind of activity. So it's not maybe just how much basic science you learn, but how you learn to put it together, how you think about it, how you become a problem solver, and you're willing to say, this piece of evidence seems to be really important, or maybe not important because of this other thing, and you can really put it all together. That's something that individual people have challenges with. And then you have the crucible of a pandemic, and you're talking about things that have enormous implications for the country. And you wind up, I think, without, the clarity of what works and what doesn't. And then people may lose faith in the whole enterprise.
Well, I think that, all pandemics stress society, and they show the weak points where things can break. The way we concluded that article in the Annals is that, maybe some of these problems that we identified and have been identified by others and by yourself, the problem of masks, do suggest that we need to have a different way of teaching so that people can handle very different types of data, especially when data may be contradictory.
Well, Dr. Casadevall, thank you for talking this over with me. It provides for me at least, some better way of making sense of all the debates, all the discussion over the last few years.
Thank you, Josh. Thank you for having me as your guest, and thank you for all you do.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.